hand over to Helen. I think you're on mute, Helen. You might have to take yourself off mute.
Sorry. Thank you, Liz. Thanks for that, and for the tip about mute. I'm just going to speak to everyone about learning and improving our response together. Could I have the next slide, please? So why is CQC involved in this work? During 2020, one of our inspectors noticed an increase in intelligence relating to sexual safety in the ambulance sector. Now, CQC receives information from a number of sources that can be staff, patients, the general public, the police, and many other partners. As this was a localised observation, an inspector and other colleagues from our analytical teams completed an internal audit of intelligence received and the actions that CQC had taken as a result. The audit indicated that allegations about sexual safety were a theme in the intelligence we received about ambulance providers. It also indicated that there was some opportunity for improvement in some of CQC's processes to support our colleagues to follow up those concerns appropriately. As well as making those small changes to procedures, we developed and delivered awareness sessions for our inspection and call handling colleagues. These sessions increased their knowledge and understanding of sexual safety, and as a result, staff felt more confident to support people raising concerns and to gather as much information as possible at the earliest point of contact, enabling them to take the most appropriate action to protect patients and staff. Next slide, Abigail, please. Having established that the sexual safety of patients and staff is a concern in the sector, CQC decided to gather more detailed information about those concerns and about how the sector is responding to them by sending out a provider survey. The survey was sent via email to the registered manager or senior person in all independent and NHS ambulance organisations. This meant we sent out just under 300 surveys, and I will go on to share more detail about the responses to those surveys. However, we hope this webinar today will support us all to address the improvement opportunities which you as providers identified in the survey. Next slide, please. As soon as we started to focus on this work, we recognised that there was no universally accepted definition of sexual safety. So at CQC, we have adopted this definition. Sexual safety refers to being and feeling psychologically and physically safe, including being free of and feeling safe from behaviour of a sexual nature that is unwanted or makes another person feel uncomfortable, afraid, or unsafe. And this can include, but is not limited to, sexual assault and harassment, being spoken to using sexualized language, observing other people behaving in a sexually disinhibited manner, including nakedness and exposure or masturbation, being made to watch, participate in, or being shown intimate images, lacking privacy and dignity when naked. Next slide, please. The stated purpose of the survey was to understand the approach to sexual safety for patients and staff within ambulance services in England. We encouraged respondents to seek the views of a wide range of colleagues and teams within their organisation to ensure the responses reflected actual current practice. We received 103 responses from approximately 300 invitations to participate, so roughly a 30% return. The survey included 14 statements which were to be rated on a continuum from strongly agree to significant improvement necessary. Participants were given the opportunity in the free text questions to tell us about areas for improvement and to provide examples of best practice. I'll now summarise some of the key findings from the survey which have helped to shape this webinar. Next slide, please. There were three notable areas in which participants felt there was opportunity for improvement. The first was around recruitment policies and practices. Next slide, please. The second area for improvement was around training and raising awareness for staff. Next slide, please. The third area for improvement was in relation to complaints policies and procedures and the link between complaints and safeguarding, especially in relation to sexual safety allegations. Next slide, please. The free text option in question 15 corroborated the responses in the earlier questions, with the topics receiving most attention being policies and procedures, training, and staff engagement. This is represented along with other themes which emerged in the Wordle on the slide. We've endeavoured to include information relating to these themes in the session today. Next slide, please. There were 5 areas where participants showed high levels of agreement with the survey statements. 100% of respondents stated they completed enhanced DBS with barred list check for all of their patient-facing staff. We repeatedly find on inspection that providers who have robust recruitment practices in line with Schedule 3 of the Health and Social Care Act have fewer quality and safety issues. Next slide, please. 99% of respondents stated they completed risk assessments where there were disclosures on DBS reports. Next slide, please. 99% of respondents also stated they had robust processes to manage any allegations made against their staff. Next slide, please. 94% of respondents stated they made referrals to the police in the event of sexual safety allegations. Next slide, please. 95% of respondents stated they made referrals to the local authority safeguarding team in the event of a sexual safety allegation. Next slide, please. The free text option in question 16 gave a broader response in terms of best practice, with many themes emerging. Key themes included the process for managing allegations, recruitment and DBS checks, and safeguarding. This is represented again with other themes in the Wordle on the slide. And again, we've endeavoured to include information relating to these themes in the session today. Next slide, please. Just to reiterate what Liz said in her previous presentation, if you become concerned in any way about the issues we covered today, we would recommend you have a conversation with your line manager as soon as possible. And if you don't feel able to discuss it with them, there's some suggested organisations who would be able to support, as well as those that Liz listed on her slide. Next slide, please. Thank you for taking the time to join today's session, which we hope you will find useful and informative. Completion of the evaluation form, which has been emailed to you, will generate a certificate of attendance, which you can use for your continuing professional development. And now it gives me great pleasure to hand over to Liz Ratcliffe, Deputy Director of Quality and Safeguarding Lead at NHS England North West, to talk about why safeguarding is everyone's business.
Thank you, Helen. Am I good to go, Abigail? Yes? Yeah, great. Thank you. Okay, next slide, please. So, safeguarding is everybody's business. We've heard that cliche so many times. But really, what we need to be thinking about is no child or adult should be made to feel unsafe. Everyone has the right to be safe from harm and abuse. All of us and everybody outside health and social care have a role to play in safeguarding, and never more so than during COVID-19. We're very privileged because we have access to patients and access to people. Health is a universal service, and the work you do also is a universal service. We have access to everybody. And sadly, sometimes people give us access unwittingly. We actually know of situations where people could wear a high-vis suit, jacket, and they can gain access to certain areas in organisations, in hospitals and other accommodation. And that is quite frightening, because what we do know, predators, sexual perpetrators, will do what they can to get access to vulnerable people. And we actually know this, and we do have the evidence of this. And this is why safeguarding is everybody's business, and we need to be vigilant. We need to make sure that people understand and have the competencies to see and notice what could be wrong. In health, we've got these documents that support our roles and competencies, which are demonstrated on this particular slide. And that also works in conjunction with the safeguarding assurance accountability that document that I referenced earlier on in the presentation. Next slide, please. So, signs and symptoms are red flags you might observe. Under 18s, an older boyfriend with an older boyfriend or girlfriend. And again, you in the ambulance service, in 111, in call handling, have access to these kind of situations where you might think a bit differently of what's going on, where there's a situation where the patient or the person is not allowed to speak for themselves. What are the questions we need to ask ourselves? How can we discreetly get some confidential information for people? Under 16 pregnancy, why is somebody pregnant under 16? Who've they got pregnant by? What's actually going on here? What can we do to support this child, because they are a child? Over sexualized behaviour, that is unusual, and we want to question that. Why would somebody be behaving like that? Aggression comes in many forms, and if we notice somebody's personality completely changing, why? What's going on? What's making that happen? Unkempt appearance or environment, they're safeguarding issues, because they're indications of neglect. They're indications of self-worthlessness. So again, what's different about this person? What could be going on? Missing from home, we get a lot of children go missing from home, and they're drawn to these areas where there are people that are happy to entice them into drug use, sexual exploitation and trafficking. Again, we need to take these situations seriously and think about what's going on beyond them walking away or having a fallout with the parents or something, or with each other if it's an adult or a vulnerable adult. If somebody's withdrawn and there's bruising in places that they shouldn't be bruising, we know when we look at children, there are natural bruises that might happen to a mobile child that's climbing or moving around. But if they're not mobile, why would they be bruising? Where are the bruises? What's significant about the bruises? What about the story that they're telling you? I was talking to a 111 call handler the other day, and what she was explaining to me was she hears so much on the end of that phone. She hears about safeguarding situations. She hears volatile situations. So they're the people that we need to make sure are equipped and able to deal with safeguarding and know what to do. The other area which we come across a lot is the reluctance for an independent interpreter, and we have to really be mindful about that. We have to be mindful that we can't always rely on family to be the interpreter, because we actually don't know what the relationship is between the family and the patient. That concept, it's probably nothing. I don't want to interfere. What goes on behind closed doors is their business. They're probably having a bad day and I'm too busy to do anything about it. Well, we've got to stop. That can't happen. We can't assume everything's fine. What we do in safeguarding, we investigate. We're non-judgmental. We investigate, but we have processes that we have to adhere to. And I will never apologise for processes. What I will apologise for if people are made to feel really bad when we don't even know the outcome of a situation. And sometimes that does happen, unfortunately. Next slide, please. So what are we safeguarding vulnerable adults and children from? I'm not going to go into every detail of this slide because you're able to read that yourselves. But the types of abuse that we come across: domestic abuse, emotional abuse, coercive behaviour, female genital mutilation, known as FGM, financial abuse, human trafficking and modern slavery. You know, years ago, we probably didn't even think about that concept. It was something that was on the TV, but it's happening. It's there. It's under our noses. You know, and we've got these people are so bright and clever in what they want to do. They will find every way that they can get modes of transport, of moving people around the system so that they're not obvious. Neglect happens in many forms. Neglect for adults and children, and that's what we've got to remember. Safeguarding is about the whole family, about vulnerable people, how we can support vulnerable people. Sexual exploitation, that's what we're here about today. What does sexual exploitation mean as well? It's got very many different connotations about what we mean by sexual exploitation. And it comes in very many forms, and that's what myself and Helen and the people we've been working together in our Task and Finish group have come across in the different modes of being able to exploit people. And radicalisation, self-neglect. It's well documented about radicalisation, asylum seekers, the protests, the prevent agenda. Again, that all comes under safeguarding because these are areas where people are preyed on that are vulnerable. Next slide, please. So what do you do if you're worried? You stop, you assess, you feel, you explore, you refer. As I mentioned before, what's not quite right? We've got access to everybody. So what's not quite right about this situation? What can we do about it? Documentation is perfect to be able to articulate what was going on at the time of the incident or the time of what you were having that curiosity about. We have tools, we have guidance, use it. We have safeguarding boards, we have websites, you must use them. Maintain that professional curiosity. If it doesn't feel right, the likelihood it's not right. Have a conversation, run things by somebody. There's always somebody around that you can run by a situation and just get that kind of feel about which way I want to go next. There's always somebody around because we run a 24-hour service in many areas in health and social care. And make the safeguarding referral. Record your actions and follow up your referral. There's no right and wrong. As long as you decide and make sure that you've documented why or what you're doing, that's absolutely fine. Next slide, please. Methods of reporting. We've got adult, and these are our protective factors. We've got adult social care, children's social care, the police directly. If somebody's in immediate harm, that's when you might consider calling the police. People, person of position in trust, you may have heard of PIPPOT, which is the acronym. There's local authority designated officers, LADOs, and freedom to speak up guardians. These are all people in your organisations that you can go to for support. If you do make referrals and you're not happy and you feel that you're not being listened to, there are processes for escalation. So please consider those and go to your line manager or look for those escalation processes in your organisation. Next slide, please. Information sharing. There's quite a lot of myths about information sharing. Do I need to consider consent to make a referral? No, in most cases. If you're protecting somebody or they're in immediate harm, it is great and it's ideal to get consent and be open and transparent with people to make sure they're aware of what you're doing. But in a dangerous situation, you don't often need that consent. And any court will tell you that they would rather you make that referral and do something about something than nothing. I can't share information under the Data Protection Act. The Data Protection Act, and if you speak to any lawyer, they will tell you it allows us to share information because there is a legal framework for vulnerable people. It's not a part of my role to get involved in safeguarding. Practitioners should not assume someone else will pass the information on. It's central to safeguarding and individuals' welfare. What referrers don't want to hear is a third-party referral, because if you're the one that's seen the situation, you've been there, you're the one that needs to make that referral. Okay, next slide, please. And just very quickly before I close, I suppose what we want to look at from NHS England's and improvements point of view, we have priority work streams. We're looking at a trauma-informed approach. We're looking at Think Family. We look at looked after children and care leavers. These are the most vulnerable in our society. We're tackling serious violence. We're preventing radicalisation. Hidden harms, domestic abuse, there's all those underpinning little nuances that cause safeguarding situations and cause harm to people. The Mental Capacity Act, Liberty, Protection of Safeguards, they're the key issues that you may come across a lot in your world. What's the capacity of the patient? What do they understand about what's going on? What are we doing with people? So they're considerations that, you know, it's something to think about how we develop competencies in these areas. Next slide, please. And just to finalise, we have a safeguarding app. This you can download on any of your devices. It gives you a comprehensive resource for healthcare professionals, carers and citizens. It's got 24 access to an up-to-date legislation. It gives you information on how to report a safeguarding concern. It includes a directory of safeguarding contacts and every local authority in England. You can search that through region, and it also explains or takes you to their website so you can see how to make that referral. And it can be accessed on your devices. And this next slide is my last slide. Thank you. Key messages then. If you have a concern, do something. You're never alone in safeguarding. There's always support available, which is something I've just alluded to. If you raise a concern and you're not happy with the response, formally escalate. There's enough people around there to give you that support. Never worry about that. There's always somebody around that can give that support. Documentation must be thorough and timely and record management standards. And please don't be frightened of that. You know, it's about understanding what was going on at that time of the incident or that time that you've become aware of a situation. Considerations going forward for the impacts of safeguarding. The pandemic, I think the ambulance services are key people that have got immediate access to the population, and it's key that you're the first responders. You've got the first eyes on people and what's going on. The COVID recovery, there's a lot about COVID recovery where we're going to have to pick up the pieces and we're going to have to deal with the outfall of COVID. We've got refugees and asylum seekers, that's well documented, and it's even increased now because of the Afghan situation. We are creating more vulnerability in society because of lockdown. We've got loneliness, we've got the excessive use of IT, and we know that that's causing problems for children and adults. And then, of course, is our inequalities, which we also need to recognise. I'll say it once again, safeguarding is everybody's business. Thank you. I'd now like to take you forward to Dr. Suzanne Smith, who's going to talk to us about disclosure and barring services. Thank you, Suzanne.
Thanks very much, Liz. Next slide, please, Abigail. I hope you're going to be ready on the next slide button, because I'm going to plough through these at a rate if not. So I'm Sue Smith, and I am the Executive Director of Barring and Safeguarding for the DBS, which, as you know, is a national organisation. And I want to underline the fact that we are a safeguarding organisation. Our purpose is just to not only to protect the people by helping employers make safer recruitment decisions through issuing of DBS certificates, but also by barring individuals who pose a risk to vulnerable groups from working in certain roles. Next one, please, Abigail. So how are we a safeguarding organisation? Well, we form one of those lines of defence around children and vulnerable adults and the public generally. Next slide, please. And if we weren't there, what would happen is there would be a layer of defence missing, and some of those holes in the Swiss cheese will line up and people will drop right through them. So next slide, please. We perform one of those layers of defence, which is really, really important. There are three types of different ways that we receive referrals in barring at the DBS. And I'm just going to talk about that first one, the discretionary referral. Next slide, please. So the sort of people who would make discretionary referrals are employers, will be you as well. I just want to underline the fact as well, because not a lot of people know this, to quote Michael Caine. You have a legal duty to refer if you are a regulated activity provider or a personnel supplier. That's a legal duty. This is in statute. So if you basically regulated activity, there's a proper definition for it that you'll find in a link that I'll send you shortly, but it's working closely with children and vulnerable adults. So the regulated activity providers and the personnel suppliers have a legal duty to make a referral to barring if two conditions are met. Next slide, please. Keep chunking on through the, there you go. One is that you have withdrawn permission to engage in regulated activity. So you've dismissed somebody, you've redeployed them, you've moved them out of regulated activity for some reason or another. They've retired or been made redundant, which was handy because they were going to be dismissed if they didn't, or they've resigned again, which would, if they hadn't have done, they would have been dismissed. So that's one of those conditions. The second is that you think that the person has either engaged in something called relevant conduct or satisfied the harm test, or you know that they've got a caution or conviction of a relevant offence. Now, engaged in relevant conduct or satisfied the harm test, in a nutshell, means that you're concerned that they have in the past, they are doing, or they are likely to present a risk to children or vulnerable adults. Next slide, please. So just going to quickly recap. So you must make a referral under statutes to DBS if you've dismissed somebody, even if the local authority and police are involved. The legal duty sits with the employer. So we'd rather get it 3 times than not get it at all. And our numbers of referrals from the NHS are much, much lower, and I'll take you through that in a minute. Could you also just check your managing allegation policies? I mean, Helen talked about policies and procedures coming up really loudly and clearly in the survey that was undertaken by CQC. Do your managing allegations policies make it absolutely clear that HR make the referrals and involve the safeguarding lead in that? But you should be checking that referral has gone. So that's a link for you to access later on. Next slide, please. The more information that we get at DBS, the quicker and the higher quality decision that we can make. Okay, so I've given you a list there of all the things that we need to receive or would like to receive if possible. Just send us as much as you possibly can is what I would say. Next slide, please. And we have 5 different stages through that involve the referred person as well, who we obviously inform before we make a final decision to bar. We can decide at any point not to bar. Okay, next slide, please. The impact of being barred is that, guess what? You're not allowed to work with in regulated activity with children, or you're not allowed to work in regulated activity with adults, depending on which list you're on. And if you're on both lists, you're not allowed to work in regulated activity with either. Next slide, please. And if you do, that carries with it, it's a criminal offence. So if you were working or seeking work or offering to work in regulated activity, either as an employee or as a volunteer, then you can you'll be fined, or you can have a maximum penalty of 5 years imprisonment. But also, did you know that if you permit somebody who you know is barred to work in regulated activity, you're also committing an offence, and that also has a pretty stiff penalty attached to it. Next slide, please. So some key facts in terms of NHS discretionary referrals. Like I said before, we just don't get enough. And given the size of the institution, it's surprising how few we get. So in 2021, we only had 403 referrals for the whole year, and that's 96 more than we had in 18-19, and that's only 5% of our referral intake. Of those 403, we barred 18 of them on one or both barred lists, and 7% were already barred, probably because we'd already had a previous referral from another route. But as I said before, you cannot assume that somebody else is going to make that referral. As Liz always has said as well, it's your responsibility as an employer to make this referral. So I'd rather receive it twice than not at all. Next slide, please. I'm not going to go through this in detail. It's reiterating what Liz has just said. There is nothing to stop you sharing information about safeguarding if you're sharing it with the relevant people and you're sharing it in good faith. And it's covered in GDPR under substantial public interest. Next slide, please. And also in the Data Protection Act, also under substantial public interest. And there's a whole section on safeguarding children and individuals at risk. So nothing stopping you sharing that information. Next slide, please. Just want to flick through a couple of case studies. We have different sides of the coin. We protect people's freedoms as well as protecting vulnerable children and adults. And this is a case study where a teacher's 3-month son had a head injury whilst in his care, and the partner rang the police. He was arrested. The teacher's regulatory agency were informed. And the only information we had was from the police, where it said that the medic stated unlikely both injuries occurred at the same time. And the referred person told medics that the child fell off his lap when he stood up. Now, often in cases that we deal with under this route of referral, the CPS, Criminal Prosecution Service, advise no further action, or if it does get to court, there's not enough evidence to prove beyond reasonable doubt that the allegations are true or not, or to actually happened. So in this case, there was no further action. We got requested information from CQC. I went to the named nurse, who went to the LADO. I got passed between the legal department and every man and his dog, basically. Next slide, please. Eventually, I did get something. We got passed back to legal. We had a bit of ping pong between data protection and legal. I did get something, and I was asking for the child protection medical, and that very clearly disputes the police information and says that the injury was probably accidental and occurred as the referred person had described. So that teacher had 19 months of wondering if he was ever going to work with children again, or if he was going to be prevented from working with children. Next slide, please. The information that is important for us in order to bar people, it's also important to stop them working with the public. So we got a referral from a fostering team back in June 17, really poor referral. only gave us strategy meeting minutes. And those of you who've worked in safeguarding and length of time know that that's very, very early on in an investigation. So there was absolutely nothing regarding anything concrete around this baby's injuries. Was it a birth injury? Was it cutting? Was it infection? And it was possible abusive head trauma. It was eventually escalated to me, which it does when nothing's moving, especially if it's to do with NHS, because I used to work in the NHS for 20 odd years. Went back to the designated nurse, again backwards and forwards, contacted the LADO. Eventually, I got a report detailing the previous concerns about the referred person, and finally got the LADO minutes, which confirmed that the CPS felt, no, it didn't meet the criminal threshold, but there was a high level of concern about the individual and the risk they presented to children. Very finally, we got a consultant paediatric neurologist report confirming the diagnosis of abusive head trauma. So those people have been barred and no longer have access to children or to adults in regulated activity. Next slide, please. And we have referred to this case, Helen and Liz have referred to this case, where we know that somebody has been accused on several occasions of sexual assault or sexual harm, and different police forces know about it as well. But it doesn't appear, there's no conviction, no caution, but the police forces didn't disclose it on the soft intelligence bit of the DBS certificate because they didn't feel it met the criteria. However, you might have more information than the police have now. So I would recommend make that barring referral, because we make a decision on the balance of probabilities, we're not looking to prove something beyond reasonable doubt. If you are concerned, make that referral. As Liz said, it's your responsibility. Next slide, please. So just to finish off, and next slide, please. How can we work together? We've all said, and we all know, we can't protect children and vulnerable adults if we don't work together. DBS has a unique and very important role in being able to do that, not just certificates, but probably more actively through our barring service. So what I want you to do, if you wouldn't mind, after this conference, is go and check your managing allegations policy. I asked CQC and I asked NHS England and Improvement, can you check people's managing allegations policies? Can you advise what should be in there to make sure there is something explicit about HR considering making a referral to DBS barring following a disciplinary, and that they involve the safeguarding lead? And the other question I want to ask is, how can we help? What will make it easier for you to be able to understand your responsibilities in this regard? And that's all I'm going to say on that subject. So if anybody has any questions, please contact me directly. I'm just checking that's the last slide, please, Abigail. And I am now going to hand you over to Grant de Jong, who is the CEO of Health Practice Associates Council. Thanks, Grant.
Thank you, Suzanne, and that's a great presentation. Thank you. I'm busy writing down lots of notes from there. Lots of very, very good points there. So yeah, my name is Grant de Jong. I'm the Chief Executive for the Health Practice Associates Council. We exist to try and cover that gap of regulation for your non-paramedic ambulance clinicians. So like our colleagues in Ireland, you have the Pre-Hospital Emergency Care Council, who will regulate everyone from your first responders right up through emergency care assistant, technician, through to paramedic, as well as the HCP in South Africa, who regulate all those groups, and of course NREMT in America. So what we're trying to do is identify, those people who are operating in the non-paramedic role in the ambulance services, responsible for some 10,000 patient contacts a day, and see what we can do just to help protect the public and protect staff. Could I have the next slide, please? So, sorry, go on to the next one. So we have a council which has existed for some years now. In our early years of formation, it was a 2-year consultation with 7 different NHS ambulance trusts, St. John's, the Red Cross, and private sector, independent sector ambulance services. And on the council, we have a good cross-section of backgrounds and experience, people bringing expertise from the NHS, from the independent sector, from the voluntary sector, and so forth. Could we go on to the next slide, please? So I'm going to be whistling through this, and I should have said at the very beginning, Kenny Gibson was going to co-present with me, and he does pass his apologies on. And actually, I'll just quickly read a little statement he wanted me to say on his behalf. It says, due to unforeseen technical issues, I'm unable to join this morning. I'm currently supporting Health Practice Associates Council, HPSC, in their endeavours to safeguard the clients, their members that they look after. The number of sexual abuse and violence incidents reported and probably unreported in which private and independent ambulance services and first aiders are implicated continues to be of concern to NHS safeguarding. And these green uniform services require regulation as with other ambulance services. So could you go on to the next bit, please? Yeah, we can just skip through. I think this is a slightly older iteration of the presentation. We can sort of skip through to the next one. I painstakingly removed slides, and Kenny was going to keep me on time, so I didn't take too long. So if we just, so the gap that exists in the UK is pretty much that little step between when a person leaves an employer and works for another employer, and of course, what happens when someone is working for an employer and they have another job in a different county. And one of the most vulnerable areas that was identified, particularly for NHS trusts who are doing their utmost to keep patients safe, as are many of the independent sector, as Alan rightly said earlier. But we have people who are working on zero-hour contracts for different ambulance providers around the country. And what tends to happen is you can have situations where there has been an event of concern and perhaps the person, as we've heard before, jumps before they're pushed and they're just going to work on a different contract. In one of my previous roles for an NHS trust, we discovered someone who had been working on contract for some 6 months, but there had been significant concerns with another trust, but they managed to find their way onto contract through the private sector. And it's not just the independent sector where the risk exists, of course not, but we know that that is an open market, and as Alan said, it's quite a large open market. For the continuity of care and continuity of safeguarding, it's important that we do regulate these people, that we have them on the radar, that you can look them up on the register like you would a paramedic on the HCPC and see that they're active, that there's not a caution or an interim suspension or something of the like. Could we go on to the next slide, please? So I've put a whole load of slides in here just so that afterwards people can download it and really get a feel of who we are. And if you don't know about us, the reason will be is that we've spent a lot of time the last 5 years getting our ducks in a row before we really do a big push on getting all ambulance services on board to what we're doing. We've been very privileged to have the recognition from the CQC, NHS Safeguarding, National Police Chiefs Council and the Independent Ambulance Association in helping to support the safe recruitment of non-paramedic clinicians. What we want to see is this reduction of the transfer of risk between ambulance providers. We often realize that it's difficult to write out a bad reference. We get that. And we also recognize that the DBS system which is fantastic, and we use it a lot, obviously, just like you. There are certain incidents that might not get picked up, as we've heard, that don't go reported. And I remember a situation where we were looking at onboarding a paramedic and looking at the DBS certificate. It was clear, but when we looked them up on the HCPC, it was unbelievable. The sort of content was on there, and it was an immediate rejection from contract. So why was that? It's because as a regulator, there is more stuff that you are able to pick up on and put onto the register, because you've got a code of conduct, you've got an expectation of, so you have a presence for people to make those referrals through to you. That's staff, that's the public, that's employers and various other stakeholders. Can we go into the next slide, please? So here's the code of conduct. So the code of conduct is pretty much a dead lift from the HCPC's code of conduct, and obviously with their permission. So what this means is your technicians, your ECAs, and your first responders, they get held to this standard, which means that they actually are far easier to pull up when they do something which, you know, has concerning behavior. Could we go on to the next slide, please? So we can actually skip this one. If we can skip this one completely, it's just a little extract from a news interview talking about the public expectation for regulation of those individuals. Now, the National Police Chiefs Council, we were privileged enough to be invited to do a presentation to the custody, to a custody suites hearing, and what we told them about the fact that it's 10,000 patient contacts roughly for the unregulated ambulance responder was so shocking to them that they actually got behind us straight away, and they've signposted the HPAC in all the custody suites across the country as the non-paramedic referral pathway. So what does this mean? So if you have a paramedic who gets arrested for drug driving, or for, you know, as we're talking about sexual safeguarding, if they get arrested for something like that, they're immediately referred through the HCPC in line with common law disclosure. Now, the police have the same recourse for your non-paramedic responders, so your technician, or your ECA, or your first responder. Could we have the next slide, please? So our system takes advantage of the fantastic facilities that the disclosure and barring services offer, and we actually have real-time monitoring of our registrant's DBS status. So this means that if someone's DBS certificate becomes invalid, and they would have to be on the update service, but if it does become invalid, our system would automatically pick that up, and we would know within an hour, which will allow us to make have a rapid reaction to that situation and inform the employer and that they're no longer active on the system, and that person will have to obviously give an account to us, because of course they have to self-refer, and if they haven't done that, that raises other questions. So that's a really powerful tool, and we're really pleased to have that working for us. Can we go on to the next slide, please? We can just go on to the next one, it's fine. So yeah, how does our safeguarding alert system work? So we have a portal for organizations, stakeholders to log into, and the ambulance staff who are on the register, they associate or link in to the employer. And so what this means that if, say, for example, someone's doing some work up north and they're employed down south and something goes wrong up north, and that gets reported to us, immediately their employer down south would receive a alert from our system. They'd only be alerted that by us if that person is associated to them. So the safeguarding lead does not get inundated with lots of referrals. So we go to the next slide, please. So some examples of the referrals we've been working with: we've had sexual assault on a staff member, sexual assault on a minor. We actually had one of the victims contact us and make a referral with social service. Contact us. We've worked with LADO. We've worked with about 4 or 5 different police forces to date. We've helped in bringing a successful prosecution against an unsafe clinician. We've been really hard at work behind the scenes just to try and, you know, reduce the public and the employer exposure and staff exposure to people who are putting on the green uniform, but taking advantage of the trust that's been given to them, and of course taking advantage of those patients as well. So it's a really, really important thing to recognize that in the short time the HPAC has been in existence, we've had many referrals already, and you know, we've had referrals from staff members as well, that, you know, referring colleagues in just as they would for the HCPC. So it absolutely makes sense that we, you know, square off the circle, cover the section around non-paramedic clinicians and get them regulated as well. We've had fantastic support and cooperation from ambulance trusts who've helped us to make sure people are accredited, etc. And of course from the independent sector as well. And other stakeholders. Can we go on to the next slide, please? So yeah, we've just got our own, this is just a little flashcard on our register and checking process. We will check that people are registered with other, have not been struck with other registers. We'll obviously go through the DBS check. We will check their credentials, etc. And it's pretty solid. So you can get that off the downloaded presentation. Could we go to the next slide, please? So yeah, this is just a screenshot. You can look someone up on the register and you can see that they're active or not. And as I say, one of the great things with our system plugging straight into disclosure and barring services system, the way that they've done that, if they're active on our system, you can be fairly confident that their DBS is still valid if they're on the update service, which is something that we're rolling out to every single one of our registrants. Can we go on to the next slide, please? Just bring up all those points there. We can skip this one, it's fine. This is just a little summary of the sort of things that we are checking, which a lot of the trusts, a lot of employers will check as well. Of course, it's just a natural part of our due diligence as well, just to make sure that we are seeing the right people get onto the register. We will do background checks, identity checks. We'll even do biometric face match checks to make sure the person matches, you know, their passport and they belong to their certificates. So this is just stuff to ensure, you know, we have that professional behavior from them and that they are who they say they are. It is about protecting the public. It is about supporting the professional behavior. It's about encouraging staff to encourage each other to get registered, to become accountable, and to actually take away the opportunity for people to hide in plain sight. When people are on the register, they're on the radar. You know, we're working with colleagues and other stakeholders to, you know, to continually improve what we're doing, and we're really excited about where it's heading. Can we go to the next slide, please? Yeah, we can go through this one very quickly. So this is just a hierarchical structure of the way the system will just allow. So for example, the NHS could have a parent organisation register and just share intelligence with other trusts if they receive referrals, and it's also possible for private, independent sector and voluntary registrants organisations. Could we go to the next slide, please? Where the system also has some really helpful little bits just to help people with their action plans and keep track of event logs of the individual who's on the register. So if you've noticed concerning behaviour within a person's profile, for want of a better word, as an organisation with access to the system, you can record that and you can build up a picture, and that just allows you, or your safeguarding lead or HR, just to have a look at the individual's track record and how they've been. And of course you can issue an action plan just to help with that, but we are primarily about regulation. These are just tools to help in the process. Can we go to the next slide, please? Yeah, we can skip through that one. Yeah, we can also skip through this one. That's fine. So what's our main message? Yes, it's help to protect patients and staff, reduce risk being passed on, support regulation compliance. And, you know, I recognise, we do at the council recognise the incredibly hard work everyone is doing. And, you know, it's a very difficult landscape out there, and we just want to do our part. We're a non-profit, we're a community interest company, which means we're owned by the public interest, and we just want to support you as key stakeholders in this difficult landscape. So thank you very much for your time, and I now pass on to James. Thank you very much.
Okay, good morning, everyone. Hope you can hear me. My name is Chief Inspector James Brown. I work for Norfolk and Suffolk Professional Standards Department. I'm in charge of the Serious Case Unit and the Anti-Corruption Unit for the Norfolk and Suffolk Police. I've been asked to come along today just to give you an input really on some of the work that we've been doing around trying to identify sexual predators, obviously within the police. As you'll probably be aware, unfortunately, it's not something that purely affects yourselves and the Ambulance Trust. It affects all sorts of agencies, particularly where there's obviously a position of trust involved. And I've been asked to come along today. We've been doing some work very closely with the East Anglian Ambulance Trust, with Anna, who's also on the call today. And we've been delivering some awareness raising input to her staff. I'll give you the caveat today, really, though, that this input, usually the input that we've been giving to her staff usually lasts about 90 minutes. So I'll give a very whistle-stop tour of some of the work that we've been doing. So next slide, please, if you could. So I think just to start off with, we'll talk about some sort of comparators between our roles, between the police and the ambulance service. We'll then move on to identification and warning signs that we picked up during some of our work. And then finally, we'll finish on sort of some detection and prevention measures that we've also picked up as well. Next slide, please. So first of all, comparators really between the police and the ambulance service. There'll probably be many more than these, but this is something that I thought of the other day when I was going through this presentation. Again, our relationship with the public is built on trust. There's very few other organisations where, you know, when we turn up at the doorstep in uniform, whether it be in a green uniform or a black uniform, that we're actually invited into people's homes. There's very few other agencies that get that sort of level of trust, where we're simply invited into people's homes purely based on our uniform. We're often making life-changing or life-saving decisions, whether it be within the police or the ambulance service. And again, quite often we're at those scenes together and working together as well. We also look at potential deprivation of liberty. So again, that's quite straightforward with police officers. Again, unfortunately, we quite often have to look to arrest people and take away their liberty. But likewise, with the ambulance service, I think you've got powers under the Mental Capacity Act in order to also remove people from locations. So again, that's that use of power that your staff have also got. Also, in terms of vulnerabilities, again, we are working all the time with people with all sorts of different illnesses, whether it be mental health, physical illnesses. We're dealing with victims of domestic abuse. We're dealing with those with alcohol and drug dependency. And I put in there, who will believe me? So again, we found through some of our research where, unfortunately, police officers have targeted people who are vulnerable. Particularly those who, again, you know, who's actually going to believe them? That's why they haven't come forward. There's some of the barriers to reporting, because they think, well, who's going to believe me if I actually report it? And people, unfortunately, will prey upon those vulnerabilities. I've already mentioned about that imbalance of power. Again, anybody who's perhaps is going to be using the law or procedures. You know, let's look at that sort of imbalance of power. Where does that balance of power actually sit? Access to personal data. So again, you know, as the police service, we've got access to all sorts of personal data held on individuals, whether that be mobile phone numbers, home addresses, criminal convictions, etc. But your staff will also have access to those sorts of personal information, whether it be, again, mobile phone numbers, where perhaps they can then contact them after they've dealt with the event, or obviously they'll know home addresses from the sheer fact that they've been there. So again, just think about the access that some of your staff have got to that sort of level of personal data. And then lone working, you know, there's opportunities and also risks there. So again, unfortunately, opportunities for predators. Again, a lot of our officers work on their own. They'll be going along to these incidents on their own, but likewise, so will some of your paramedics. I know they've got single crew vehicles where they'll be going on their own. So again, there's opportunities if they are predators, but also, as we know, unfortunately, there's also risks of false accusations, and we have to look at ways that people can protect themselves. And again, you'll be aware that near enough all police officers now across the country are issued with body-worn video, and I know that's something that perhaps some ambulance trusts are looking at as well, albeit you've got different considerations around privacy that you'll need to consider. And then finally, use of force and physical contact. So again, police officers quite often have to lay hands on, as we call it. They have to use force against individuals, and we need to make sure that they're not using those powers gratuitously. But likewise, again, your ambulance crews, they can only do their job, can't they? By unfortunately laying hands and touching people, you know, in order to provide medical treatment for them. And again, that's where some of those risks and opportunities for perpetrators and predators come about. So next slide, please. So again, these are just some of the possible warning signs. Again, there'll probably be many more. So again, police officers quite often are seen as that knight in shining armour. We're going along to incidents where people have never ever called the police in their life, and we're happy to go in and potentially sometimes save their lives. And quite rightly, sometimes, unfortunately, we are seen as that knight in shining armour. It's important that officers obviously don't play upon that role they're given. And likewise, again, your staff are going to be going in and more often than not, sometimes, again, saving people's lives. Sometimes we find that a member of the public will have a favourite officer who they will phone up and ask for. And again, might not be anything wrong with that, because again, the officer might have done a really good job, but again, it might be a potential warning indicator to us, where again, a member of the public is phoning up and asking for a particular officer all the time. Again, that might not happen so much within your service, but again, that's something that we've picked up within the police. Unexpected visits, again, if an officer was going around and visiting a victim, quite often we've got a reason to do that. But again, if there's an unexpected visit, and again, those visits are taking place on a regular basis, again, that might be something that we're concerned about. Again, might not be something that happens within your trust. Favourable decisions. So again, this is where we've had that imbalance of power again. So again, we may have a police officer who stops someone for a speeding offence or for using a mobile phone. And again, unfortunately, we have seen situations where again, the officer has asked for that for the mobile phone number of the person who they've stopped in order for them not to receive a ticket. And unfortunately, we've also seen incidents where officers have actually been engaged in sexualised behaviour for not providing someone with a speeding ticket or for a mobile phone or something similar to that. So again, those sort of favourable decisions in order to in return for sexual favours, unfortunately. Flirtatious behaviour, again, something which again, your staff hopefully won't get engaged in. But again, when they're dealing with members of the public, we've certainly got really high standards of behaviour we expect of our staff. And we certainly wouldn't be expecting any of our staff to engage in any sort of flirtatious behaviour. So again, that's something that again would also be a potential warning signal for us. Nicknames and pet names. So again, if someone is having regular contact with the same member of the public, again, we'd be really concerned if they somehow had some sort of nickname or pet name for them. Again, that would demonstrate to us a certain level of unprofessional contact between them. Then we move on to unnecessary communication, that being through social media or phone or email. Again, we've got really strict instructions to our staff that at no point should they be handing out their personal phone numbers or any form of social media contact to any members of the public. There's no reason for them to do that. They've all got tablets issued to them now. A lot of them have got job issued phones. So there should be no reason whatsoever for them to be handing out their personal phone numbers to the members of the public they deal with. We would be very concerned if they were doing that. And again, that might be a potential indicator to us that we need to know about. Kisses on the end of messages, and again, with some of the flirtation emojis and other sexualised comments, again, from some of the language that we have picked up, particularly on some of our force-issued mobile phones. Again, we've got access to audit all of their text messages that they send. Again, this is where some of our auditing work in the background might pick up on indicators where they've perhaps put like the kiss on the end of a message. Again, that would be a real concern to us on any sort of force-issued device with people using that sort of behaviour. And we've been doing some audit work around that. Contacts or visits off duty. Again, there's no reason whatsoever why a police officer should be visiting a member of the public off duty, even to go around and do any sort of welfare check. Again, that would be a real risk, not only to them in terms of accusations, but a risk to the member of the public as well. And quite rightly, I wouldn't imagine that any of your staff would be doing or shouldn't be doing any visits to patients off duty. Presents, gifts and letters. And again, might not be anything wrong with an officer receiving a gift. Sometimes we obviously hopefully do a good job, and we will receive gifts or a letter of thanks. But again, if the same officer was getting regular gifts coming through, again, that might be of concern to us. Continued contact after an incident or cases is concluded. Again, an officer will be obviously quite rightly in contact with the victim throughout their case. There'll be a certain cut-off point where we wouldn't expect that contact to continue after that. And again, that might be something that would be a risk to us as well. And then finally, the use of dating websites and risky sexualised behaviour and affairs. We often say we are not the moral police. My department, we are not the moral police. We, unfortunately, during our work, we will come across some really sensitive information about individuals, whether that be use of dating websites or having affairs with colleagues. And again, we are not the Norfolk Police. However, if that's repetitive and is seen as an individual, and perhaps we all know those individuals within our organisations who perhaps may display those sorts of behaviours, again, that may be an additional risk that we might want to consider. You know, how much is it for them to then step over that line to then have some sort of sexualised contact with the member of the public? And you'll see there on the right-hand side, I put the victim will often see there's nothing wrong with the relationship, how it started. So quite often when we go and see the victims in these cases, again, they'll think, well, what's wrong with me being in a relationship with an officer? And it's only until we sort of point out that imbalance of power, you know, how did they actually officer form that relationship with them? They'll actually then start to realise that actually, yes, they were preyed upon at a really vulnerable time in their lives. So next slide, please. So we've got as you say, the National Police Chiefs Council commissioned the University of Bournemouth back in 2017 as this issue was raising its head within the police service. And we contacted the University of Bournemouth and commissioned them to do some work around developing a risk assessment tool for us, so we could try and identify some of these officers earlier and police staff earlier who might have used their position for sexual purpose. There's a data collection of over 500 cases from 33 out of 43 forces. You'll see that there's just some headlines in here. There's a lot more research to come out and data to come out from this research. But 72% of the sample were between the ages of 31 and 50, and that's largely supported by some other work and research that's been done as well. Majority of the officers had less than 10 years service. In terms of marital status, just over half were either married or in a committed relationship. And it won't surprise you, unfortunately, that the majority of the offenders were male and the victims were female, with only very few exceptions. Just under half of the sample had some kind of sexual-related intelligence logs prior to the investigation into the abusive position for sexual purpose. And over a third of them had in excess of 6 disciplinary events. And again, I just put there, does the NHS/Ambulance Trust have any method of logging that sort of intelligence? So transferees were also linked to a high number of risk behaviours and overall came out as being of increased risk. So again, we've now got a framework in place for sharing any, obviously not only just normal information about people transferring from one police force to the next, but also our counter-corruption units will also be in contact with each other and will share that intelligence which the officer might not actually know anything about. So again, we've got a process in place for that. So also the research picked up behaviours which obviously indicate issues with their sort of work ethic and their conscientiousness. There's a link to suggest that lack of work ethic is related to an increased risk of all forms of corruption, but also abuse of position for sexual purpose. And in police officers, there's things like going missing on duty, taking long work breaks, long breaks from work, poor standard of work, and behaving in an inappropriate way off duty. For example, flashing at a work party, unfortunately. And again, as I said earlier on, having extramarital affairs on duty, etc. So again, that's just some of the research that's come out. And having spoken to the lead researcher from the University of Bournemouth recently, she's very interested in doing some further research for the Ambulance Trust. So that might be some work that she can do for you. Next slide, please. So again, just some very quick ideas for detection prevention. You need to have, you know, certainly in the police, we've got a real clear and unambiguous corporate message around this sort of behaviour. We have regular campaigns and publicity raising campaigns within forces. That's included on our internal intranet pages. We also publish all our misconduct findings. You may well be aware that any gross misconduct hearing now is held in public. There's any very rare circumstances when they're not. So again, the public gets to hear of any gross misconduct finding. And we also engage in a lot of training to both new students and supervisors to make those messages really clear around what is acceptable and what isn't. Early identification of potential sexual predators is vital. Sometimes when we pick up on some really low-level intelligence, we may decide to actually hold what we call a vulnerability interview with that member of staff with my colleagues from the anti-corruption unit, and to point out why those behaviours are risky. And again, that can be a really powerful deterrent. Organisational memory is also really important. You know, supervisors move on, and quite often we found that no handover is completed between supervisors to pick up on those low-level risks and concerns. So again, part of our performance development review process, we try to pick up on those sorts of issues there with a handover between staff. Awareness raising with partners. Again, you are our eyes and ears, which is why I've been doing the work with the East Anglia Ambulance Trust. Again, your staff are going along to the same sort of incidents, and vice versa. So again, that's where we can raise awareness. You can be our additional eyes and ears out there to pick up on some of those indicators, and also vice versa. We've also been looking at some psychometric testing at recruitment to see whether we can tease out some of these issues and people's attitudes towards the public. And again, it's important to have confidential reporting systems both internally and externally. So we've got a confidential anonymous online reporting system internally for staff to report those sort of behaviours. And again, we've seen, quite pleasingly, we've seen staff report these sort of behaviour, but also we've got an external anonymous corruption reporting system as well. I talked earlier about audits of systems. So again, we've got a wide range of software tools that we can conduct audits of systems to see who's had access to particular records, which again might indicate that people are concerned and why are they checking those sorts of systems. We've also been doing some work around phone records. So again, I mentioned earlier on that police officers have got mobile phones issued by the force. So again, we can pick up on high volume callers to a particular number, and again, then do some research and some health checking around that. And then finally, we've got a national working group formed around abuse of position, which is formed with police officers across the country, which is chaired by a chief superintendent. And again, that's where we look to share good practice and tactics and techniques in order to identify and prevent this behaviour as well. And that's the end of my presentation. I understand that we should be having a comfort break at 10:50, which also we're slightly over time on for 10 minutes. So I'd imagine we're still going to go for that 10 minutes. Yes, I've got a thumbs up. So I'm assuming then we're going to return at 10:53, please. Thank you.